That's fine. As we get the slides moving here, our first order of business is that we would like to welcome a new committee member. Oh, I'm sorry. It's our meeting minutes. Thank you. So we sent out the meeting minutes. Actually, Dawn sent them out on August 5th. She received feedback and then she sent out the final copy again earlier this week. And so hopefully people had a chance to review the meeting minutes. And is there any discussion on the minutes? Okay, hearing none, can I have a move to approve the minutes?
This is Ron Gallinat. I'll move to approve the minutes, excuse me.
Thank you, Ron. Do I have a second?
This is Mary Beth Carino from OzPark. I second.
Thank you. Okay, the minutes are approved. Okay, got ahead of myself. Now I can welcome Joni Moore to the committee. So we had one spot left on our committee. We are now fully filled on our committee, which is great. And as many of you may be aware that we were specifically looking for a tribal representative, and we were fortunate enough to find Joni. And Chicky Victor and I had an onboarding call with her earlier this month, which was great. We learned a lot about Joni, and I asked her if she wouldn't mind to say a few things about herself. Thank you, Joni.
Good morning, everybody. So I'm Joni. I am a native Oregonian. I currently reside in Roseburg, where I am employed by the Cow Creek Band of Umpqua Tribe of Indians as their senior human resources analysis. I oversee their health plan and sponsorship programs with the tribes. Tribal members, and also perform risk management duties for their commercial property and auto coverage. I am a licensed health and life and property and casualty agent in Oregon since 2003. Since 2016, I have worked with a good number of tribes in the Oregon-Washington area, a couple other tribes in Idaho and in the Midwest as well. So my exposure to the operations with those tribes, I feel has given me the knowledge that I hope that I can bring to the committee as far as tribal operations. I am not a tribal member, but I enjoy working with the tribes and just learning the how different they all are. There's not one tribe that operates the same, though they all have similar needs. So I'm excited to be a part of the committee and look forward to the future here. Thank you.
Thanks, Joni. Good. Okay, so thank you for doing that. And next we are also going to meet our new interim health policy analytics director, who's replaced Jeremy Vandehey, Ali Hassan, who's I'm familiar with from all of my work with OEB and PEB over the years. So thank you, Ali, for taking on this responsibility. And I'll turn it over to you to introduce yourself.
Oh, thank you so much, Chair Anderson, for the nice welcome. I really appreciate it. And I really appreciate the opportunity to meet you all. I see a lot of familiar faces, actually, names and faces, which is always nice. And for those of you I haven't had the opportunity to meet yet, my name is Ali Hassoun, and I use he, him, his pronouns. I've worked in public service for about 24 years and have been really fortunate to work for some agencies that afforded me some really unique opportunities and experience. I started my public career working for the Executive Department Budget and Policy Office in the Department of Administrative Services, and enjoyed the chance to work on statewide policy issues, including the development of agency budgets, where I pretty much learned how to say no most of the time, but I really did enjoy that work. And I then had the opportunity to, I also had the opportunity to work with the new incoming governor's transition team, which will be occurring again in after November. So I then had the fortunate opportunity to help bring up 2 new programs in the Oregon Educators Benefit Board in 2007, working hand in hand with Ron Gallanet, and also the Oregon Health Insurance Exchange in 2011. With both of those, I was charged with building the financial infrastructure for the startups, and I probably enjoyed those experiences more than anything in my career, just getting things off the ground. I think with the exchange, I was in a house in downtown Salem with about 5 other people, and then it just grew from there. But I've worked for the Public Employees Benefit Board and OEB in leadership roles since about 2012. Including the last 4 years as director of the programs, and just taken on the interim health policy and analytics director role as of this month. In addition to my PEB and OEB role, I'll probably continue with the interim role for about the next at least 6 to 9 months, and until they hire a new governor, elect a new governor, and they can hire a permanent director. So I am really quite passionate about the Marketplace program, and really hope to be able to contribute in any way I can, and look forward to getting to know you all better in this interim role, and appreciate the opportunity to help serve Oregonians. So thank you.
On the committee? Doesn't look like it. Thanks again, Ollie. I just really feel like we're fortunate to have you in this role, given your experience. And again, thank you for taking it on.
Thank you so much.
Yeah. All right, so next on the agenda, we have Stephanie Keenan, who will go through federal health policy, or the federal health policy updates.
Well, good morning. It's good afternoon here in DC. I have a few things, not a lot this right now, but a couple of things that are important. And I want to provide some background to a couple of things. As you know, the Inflation Reduction Act included the language to extend the premiums until 2025. That's 3 years extension. You may ask yourself, why didn't they just make it permanent? I know that the chairman of the Finance Committee at one point said I'd make them permanent if I could. The reason is money. The CBO estimated that a permanent fix would be $25 billion per year. And this is not uncommon in legislation where they're trying to do something, but the fix is very expensive, so they extend it, and then there becomes this kind of pattern where they keep extending, and eventually they find a way to pay for a permanent extension. But at least they got the 3 years out, and that gets them beyond the 2024 election, which is what some of them were concerned about. The second big item is the family glitch fix rule came out on Tuesday. That's a rule that's from Treasury. The proposal didn't change substantively from the draft. It focuses on the ACA provision that entitles low-income Americans to get premium assistance if their employer or sponsored insurance doesn't reach certain thresholds. It's estimated that it will affect 5.1 million people, largely the majority are women and children. It isn't a perfect fix, and there are a number of people who wanted more out of the administration, but because it's an administrative fix, they could only go so far. It does pave the way, should Congress want to go back at any point in the near future to try to do something more, because since part of the problem with what Congress was proposing earlier in the year was that it was a very expensive fix. Because the administration has acted, the cost for Congress to act goes down. I will be honest and tell you that when Congress comes back from the lame duck, doing something more on this is not on the agenda. But if the next Congress wanted to do something, it wouldn't be as expensive. The last substantive issue I want to talk about, and then I'm going to talk about Congress's schedule and what's on the agenda, is surprise billing. They finalized the rule in August. I just want you to be aware there was a lawsuit filed by the Texas Medical Association and another one by the American Hospital Association. They withdrew those suits and then turned around, and the Texas Medical Association has refiled a suit, and the American Hospital Association and the American Medical Association are going to file amicus briefs in that case. The issue, and unfortunately they're not exactly wrong, is when CMS and HHS and wrote the final rule on surprise billing, they quite frankly blatantly left out some provisions that came from the Ways and Means Committee. And the Ways and Means Committee chairman wrote all sorts of letters to HHS saying, how dare you do this? And you've got to go back and put them in. And HHS said, well, no, we don't really have to. And that's what this lawsuit is about, is that there's some provisions that they felt were important for providers and in the negotiations over the surprise billing fees that got left out. So more on surprise billing to come. The last thing I want to talk about is Congress's schedule, what to expect. They funded the government through December 16th. Congress returns on November 14th. On the agenda is funding the government past December 16th. And those negotiations have sort of started. They kind of have a framework, but they haven't agreed on top line numbers. And that's because since there's an election this year, whoever actually wins the midterm, even though they won't be in the majority, they will have more leverage to negotiate. So everybody's sort of holding their breath to see what happens. So funding the government, there are a number of healthcare, known as healthcare riders that may go on that, including things like having Medicare cover telehealth. Some Medicaid issues may float onto that as well. And everybody's trying to figure out what's going to happen with a package of provisions that haven't been finalized yet. It's a bipartisan effort on mental health services and trying to expand access to a variety of services, including opioid treatment. So that's probably what's going to happen at the mad dash to get out for Christmas. And because Congress isn't in, it's pretty quiet right now. And the administration is also sort of taking a deep breath on some healthcare issues, but we expect more to come. And I know that some of you may want to ask about the public health emergency. So I'm just going to say that up front, that my sources say to me that they're not going to look at repealing the public health emergency until 2023. The issue is how early would they have it in 2023? I think a lot of people are banking on it sort of disappearing in January. I think if it's a bad winter, we may have it into the spring, but I think most people are planning on seeing it disappear around January. With that, I'd be happy to take any questions.
Stephanie, good morning. This is Om.
Oh, go ahead. Go ahead, Om.
Yeah, I have a question in terms of just understand it. In regard to Inflation Reduction Act, that in September the CMS launched no cost for vaccines, would that can be reversed later on? Let's say if the administration change in the near future. Thank you.
There is definitely an effort by this administration to start to push out that COVID vaccines eventually will no longer be free from the government. But when that will actually happen, and I can't give you a date, but that's what they're looking at trying to do. And part of that has to do with how long the public health emergency lasts. Part of it has to deal with whether they feel that they can get the vaccines will still be accessible to folks if the government doesn't pay for them. But they are doing things to try to make sure that individuals get them. And in fact, I'm trying to remember this off the top of my head. I think there was something they announced that had nothing to do with Congress, that there were, for certain treatments, if a physician treated someone with one of the antivirals that the patient had no insurance or was underinsured, the provider would still get paid by the federal government for that, and the dose would be swapped out for something in the national stockpile. So there's a lot going on about COVID and treating COVID, but the goal eventually is to get it out of the government's hands and have it be something that is definitely in the private sector. Anything else? You're a quiet group today.
This is checking in the room. So today is supposedly the end of the public health emergency, right? For the current extension. I have not seen anything, but since it's already afternoon over there in DC, have you seen anything about the official extension announcement?
I just checked before I got on and I did not see it. That doesn't mean they haven't done it. It just means it hasn't hit my inbox yet. But since there was no notice 60 days ago that they were going to end it, the assumption is they're going to extend it.
Okay, thank you. And then just for curiosity purposes, are they only allowed to extend it like in 90-day increments, or can they extend it further than 90 days if they wanted to?
Oh, that's a good question. I don't know if legally, most of the things that they do are in 90-day increments. Not just extensions, but other things that they work on as 90 days. I don't know if that's a rule, frankly, or if that's just the way they work, because they have data that rolls every 90 days. I'll have to look that up for you.
Thank you. Appreciate that.
Yeah, just to follow up on that, my understanding is that the public health emergency was supposed to end in January because that was 90 days from this date. And then there's supposed to be a 60-day notice, which we would hear in November. Those were the dates I was working on. I don't know if other people on the committee were tracking that as well.
Yes, so that's the timeline we are working with also in OHA, ODHS, and DCBS in terms of our planning for the public health emergency and winding portfolio. Is the next extension would be January 13th, roughly, of 2023. We should know by mid-November if they are going to really end it. And if we don't hear back, we'll assume another 90-day extension.
Right.
Great. Any other questions for Stephanie? Well, that was a complete report, Stephanie. Thank you very much. And I know it's kind of quiet now before the elections, but I'm sure things will be picking up.
It will be. Take care.
Okay,
Bye-bye.
thanks. Oh, good. So next, I think we have someone. Actually, we have, is it Tim Hinkle that's going to sub in for Tasha?
Yeah, this is Tim.
Great, thanks, Tim. Good, yeah, we'll hear your report on 2023. I see it says preliminary private health insurance rates. I'm guessing those are finalized at this point?
Yeah, they're finalized, and they've been submitted to CMS and everything. They get their final rates. Yeah, this is for the 2023 benefit year rate review, and it was a welcome, kind of a quiet year for a change, which was we're very thrilled with that. But so the rate requests came in on the individual side, 2.3% to 12.6%, and on the small group side, 3.4% to 10.6%. And almost all of these were approved as filed. And really the only changes to the initial requests were just due to the timing of when the risk adjustment report finally comes out. And that always comes out, in the middle of our rate review session. so that, we kind of always anticipate there's going to be little tweaks here and there, but the tweaks were a few percent here and there. And I believe the vast majority of them ended up being reductions because of the overestimate in risk adjustment payments. But this year, similar to many other years, the driving factors are trend, and trend is medical inflation, expected utilization changes, even deductible leveraging plays a little role in that, and changes in the experience. And so this year, the trend ranged between 2.2% and 6.6%. And so you can see that the rate increases actually kind of line up with that for the most part. There's some above, some kind of below trend, but for the most part, a lot of the rate requests were trend plus some changes in experience. And this is kind of the interesting part was, so when the carriers submit their rates, they have to look back 2 years at their experience for their starting point. So as an example, in 2023, they look back at the 2022 experience, or excuse me, the 2021 experience, and use that to project it forward into 2023. Similarly, last year for the 2022 rates, they looked back at 2020 and used the 2020 experience. And so even though we're several years past kind of the initial COVID dampening of claims and pent-up demand, once the restrictions were lifted, that still plays a role in the rates even today. And so a lot of what we were seeing was in 2022, the carriers had to essentially make a guess as to how much kind of this rebound once the restrictions were lifted so that people could go back to the providers. Once that was lifted, they had to kind of make an estimate on what utilization would look like when it returned to normal. And so that was put into the rates in 2022. And in 2023, we actually had 2021 experience to look at, which really was it was after the restrictions were lifted and people went back to providers to get services. And there was some pent up demand. So some of those services had shifted from 2020 to 2021. And so it was kind of a juggling act and a little balancing act here on our side to review these and determine what was kind of a reasonable range in terms of what was pent up demand, what was just actual experience, what was just the return to normal, and what did that look like. And so we ultimately reviewed these and decided that all the carriers were within a reasonable range, and so no adjustments were made for that. And we still have the reinsurance program, and the reinsurance program is it's used to reduce the cost of high cost claims. So the claims come in, the program pays a portion of those claims to the carriers, which in turn actually will keep premiums lower. And we always kind of are hovering around the 6%. And so the reinsurance program tends to keep the rates down by about 6% versus what they otherwise would have been. And so that's still in place, and that's still doing its job. Okay. And then I have one other note here, and I want to talk a little bit about the Inflation Reduction Act. This kind of did draw out our rate review a little bit because of the timing. Again, when this was passed, it was we'd already kind of made our decision on the rates, and it's important to note here that when we asked the carriers to file, we asked them to file assuming that the subsidies would end at the end of 2022. And it's important to note here is when the subsidies, if you expect the subsidies to end, you'd expect fewer people in the market the next year, and that would have some implications on the average morbidity of the market. And so that was one of the things that we asked the carriers when they filed. It was, what impact to market morbidity would you anticipate if the subsidies actually were to continue? What would you expect to see? And the carriers pretty much unanimously said very, very little impact. to the average market morbidity. And I would like to note that when the carriers filed, recall that they assumed that the subsidies would not continue. They made no adjustments to increase the rates for the ending of the subsidies. And so there was quite a bit of discussion behind the scenes, on our end. And we ultimately concluded that the carriers already were including the savings of the subsidy when the Inflation Reduction Act was passed and the subsidies were to continue. The carriers already had the savings present in those rates. And so we ultimately decided to go ahead and just make no changes to the rates. And ultimately, everything was approved. Almost everything was approved as filed. But again, the range on the individual side was at 2.3% to 12.6%. And then on the small group side, which the Inflation Reduction Act didn't have much of an impact or much of a discussion over there, but it was 3.4% to a 10.6%. Are there any questions about that?
So the 2% to 12.6%, how did that compare national averages? How did Oregon fare in terms of the rates, increases in rates?
That's a good question. I did not compare this to national rate increases, but I could certainly get back to you on that.
So much, Tim.
Cheeky, this is Andrew. I don't have like a detailed comparison in front of me. I've definitely track and chat with other commissioners around their rate increases. And I think ours is towards the lower end. I think we've seen, double digit, even 20% or so increases in a number of states across the country. Some of our neighboring states, I think California was within a few basis points, on their average, similar to us. So, I think on the lower end, but I'd say I definitely saw a trend of higher rate changes for next year across the country.
Do we have any other questions for Tim? Well, Tim, I have maybe a comment more than a question, and it's your note about the change in morbidity because of the Inflation Reduction Act. I think that's important for the topics that we're going to be talking about later today when we talk about the bridge plan and the impact of maybe moving members out of the marketplace if they were to go into the basic health plan. I mean, a similar analysis I think would have to be done when reviewing rates. And I think that'll be 2024, potentially, if that goes into effect. So it's interesting to hear you talk about that. And then I guess the other question, you said it was kind of quiet this year, and in the slides we have a couple documents that also show coverage by county and a map. Was there any changes worth noting in terms of carrier coverage that you saw in the rate review process?
No, I believe it was very, very similar, if not the exact same, in 2023 versus 2022.
Okay, well, that's good. Good stability then this year. Well, good. Thank you for joining us on short notice. We appreciate it. And next, I think we were going to go on to Katie Button, who will talk about marketplace plan management and the 2023 plan offerings.
Yes, good morning, everybody. I'm Katie Button. I do plan management for the marketplace. I'm going to do a fairly short presentation today, and if you have questions, feel free to ask during the presentation. There will be time afterward. I really just kind of want to give you answers to things that you're thinking about rather than here's what Katie Button thinks. So on to 2023. So as Tim just mentioned, the Inflation Reduction Act passed, which continues the ARPA subsidies, which is really great for everybody. It decreases the amount people are expected to pay for their coverage, and then it removes that 400% income cap So it's really just based on the calculation of your income and the second lowest cost silver plan. So people can be eligible for tax credits at higher incomes. Next slide, please. And so then it keeps those increased APTC amounts, which is great for folks. It really helps keep those premiums lower. More people qualify for tax credits. And then the special enrollment period for folks who are at or below 150% is extended. And so that special enrollment period is every month. If someone you know has an income of 150% or below, they can enroll anytime, not just open enrollment. And that is really helpful for folks who might not know that they're eligible. And those folks are eligible for the very maximum amount of tax credits. So they're going to see a $1 silver plan, they're going to see $1 bronze plan. So we really want to get those folks in and make sure they know what they're eligible for. Next slide, please. Family glitch. So just in case you aren't familiar with the family glitch is a drafting error that was unfortunately put into the ACA. And what it does is it sets an amount that's considered affordable for employer sponsored premium. And so that amount for this year, I believe, is 9.12%. And so there is a calculation to say, is the employee only portion more than 9.12% of income? If yes, that's unaffordable. But what the bill neglected to do is include if the family portion is also over 9.12%, and that would be unaffordable. And so unfortunately, there were situations out there where the employee coverage was affordable, the family coverage is not affordable, but folks were not able to purchase plans with tax credits on the marketplace. So when we made these slides, the rule had not been finalized, but the rule has just been finalized. So for 2023, for folks who have employer-sponsored coverage, they will have two calculations. They'll do the regular employee calculation, and then they'll also do a family calculation. And we are working with our vendor who does our window shopping site to have a family glitch calculator. It's almost ready to go. It looks awesome. And so folks coming to our site will be able to input information and see if their employer-sponsored coverage is affordable or not. And they'll be able to do that both within our window shopping tool and then outside as a standalone calculator. And then healthcare.gov obviously is also making corrections to their applications so that folks can get the correct amount of tax credit. Next slide, please. This is our coverage map. Tim just had it up a little bit ago. These are the medical carriers. As you can see, Lincoln and Deschutes County has 4 carriers. Most of the other counties have 5, and a few have all 6 of our medical carriers. Next slide, please. And here is a list of our carriers. So these are individual market carriers. We have 6 medical carriers. They filed a total of 77 plans this year, and consumers will see between 26 and 62 plans, depending on which county they live in. We have 6 dental carriers who filed a total of 20 dental plans, and consumers will see between 14 and 20 plans per county. And Don, I can't remember, do I have another slide after this? Oh, I do have a couple more slides. I told you I was trying to make my presentation short so I can answer questions folks might have. So these are our standard plans. We have a standard bronze, silver, and gold plan that we require here in Oregon. We require all of our carriers to offer them. We do have to make updates to those plans every year to make sure that they stay in actuarial value that they're required to. And so these are the changes. We generally, GFR creates the bronze and the base silver plan, and then I do the CSR plans for the silver and the gold. We work really closely together. We try to make them kind of all a match set. So we try to keep the cost sharing down, so like the co-payments and co-insurances. And so we usually end up making changes to the deductible and the maximum out of pocket. So that's what you can see here. I'll note that on this slide, the 94% silver plan and the gold plan did not have a change to their maximum out of pocket, but we included it because all of the other ones did. And so just for a nice round chart. So those are the changes from last year to this year. Again, the co-payments and co-insurance amounts did not change. It's just deductibles and the maximum out of pocket. Lastly, Regions has made some changes to their network. They, in 2022, had a network that was just in the Portland area, and it was just for OHSU, and they're newer to the market, so they're kind of still figuring out what folks like and what folks don't like. So they've decided this year for 2023 to not continue that OHSU network. They do still cover the same providers. They cover them in their individual and family network. So folks who were enrolled in the OHSU network plans will get rolled over to the individual and family network. And then every so often this happens, we like to call it a technical special enrollment. There are certain plan numbers that if you discontinue them and move folks to a different plan, it's considered a loss of coverage by CMS. And so those folks who are enrolled in those 3 plans there at the bottom of the slide will be eligible for a special enrollment period due to loss of minimum essential coverage. And so they could enroll 60 days past December 31st. And I know that this is my last slide. So if there are questions about plans in general, plans for 2023, I'm happy to answer them.
On this topic. See, we have a hand up.
Hi, regarding the last slide, were those numbers for an individual or for a family plan?
Those are just the individual, the per person amount.
Okay, thank you.
Thanks for that question. Any other questions? Katie, I think I have a general question for you because I think plan management is obviously something that the marketplace is responsible for, and that's you're directly involved in that, obviously. But can you expand on that a little bit? What it is that what you're looking at every year in terms of plan management and the kind of feedback that you give to carriers? Do you do that?
Yes, sure. So I'm fortunate to have worked with all of the carriers for a really long time. So when I'm looking at their plans, I'm making sure that all of their standard plans are meeting all of the things that they're supposed to meet. I also I look across the plans. So I'll scroll and scroll and scroll, and I'll be like, all of your benefits are subject to deductible except this one. Did you mean that? Sometimes that's a mistake. And then generally, I just let the carriers file what they feel like. Where I sometimes get involved is the crosswalking. So carriers will crosswalk folks from one year to the next, and that's what helps with auto enrollment. And so then, like in this Regent slide here that's up, since those plans aren't there, they're going to move folks into these other plans that are similar. And so I would, sometimes I might ask a question and say, well, is this network really the same? Or, I noticed that you moved these people to this network, but it seems like this other network might be a better fit for them. Sometimes I do just direct the crosswalk. We've made changes to standard plans over the years where I've told the carriers, do not crosswalk these people to this plan, crosswalk them to this plan. And then another area that happens sometimes is if a carrier decides to leave a particular county, I have to choose which carrier people go to for the crosswalking. And so that's another time when I will look and kind of see what plans might be similar, what networks might be similar, and move folks there. And then mostly it's just a collaborative thing with the carriers to go back and forth. I make sure that they've reviewed all their plan data a zillion times so that we hopefully have correct plan data to send off to CMS at the end of the summer. And then we just continue to kind of monitor things throughout the year and see, do we need to make changes to things, or are things going okay? Go ahead.
Thank you. Good morning, Katie. So I'm looking to your last charge on the maximum out of pocket. So I assume that health saving account, the out of pocket is the same, is around 7,000. Is that correct? Do you have any idea how people choose the bronze plan? There are more bronze plans than the health saving account plan in the marketplace.
So health savings account eligible bronze plans, high deductible health plans, those can be really great for people who have, who are able to contribute to a health savings account. For a lot of people, I think the bronze plans that have copays are a better option because you know exactly what you're going to pay when you go to the doctor. It's not going to be subject to deductible. And then the carriers, again, I let the carriers file the plans that they see people wanting to buy. And I can tell you that the most popular plan in our market is a bronze plan with pre-deductible coverage, and folks know what their copay is going to be when they go to the doctor. So because I don't get data on our enrollees, I just kind of have to look and see who's enrolling with which carrier. I can see certain trends, like a lot of times if a carrier decreases their rates a lot, I'll watch people kind of migrate to that carrier. But most of the time, I just let the carriers do what they do. I let the consumers choose the plans that they like, and then the carriers will make adjustments. If they offered a plan or network that wasn't very popular, they usually pull that back and try something else.
Hey, thank you for that question, Om. Any other questions for Katie? Well, thank you for your time this morning. Okay, we're ahead of schedule, so we might mix things up a little bit here to try to keep on track with our public comment period. So I believe Amy Coven is on to talk about open enrollment marketing for later today, but Amy, if you're willing, would you possibly do your piece now since we're ahead of schedule?
Yeah.
Thank you.
All right. Well, thank you everyone for having me. Again, my name is Amy Coven and I'm the stakeholder and communications analyst for the marketplace. So today I'm going to be talking a little bit about the findings of our focus groups and how that's playing a role in our marketing tactics for this year. Next slide, please. So for our focus groups, we did 3 focus groups this summer. One of them was, we focused them on different demographics to make sure that we're getting a mix of input and thoughts and things from around the state. So we had, the first one was rural, people who lived in rural areas. The second was a mix of rural and suburban, and then the third was urban. And you can see here on the screen when those were, how many folks participated in each. And then we did have some different cultural expertises in the different groups so that we were sure to get a variety of inputs. We did focus our, the focus of our focus groups, the people who participated were largely within, primarily within the range of folks that would qualify for marketplace coverage, with a heavier emphasis on kind of the lower side of the income scale so that we could get some input from folks who might be coming off of OHP or are newer to the marketplace or really impacted by the savings that folks can get. Next slide. So now I'm going to go through some different perceptions that we got, that we gathered through the focus groups. The first is that cost was clearly the top issue when it came to health insurance. Not just the cost that, you know, people obviously are very concerned about how health coverage and health care will fit into their monthly budget. But a lot of what we heard about as well was just the uncertainty of what was covered and how much the benefits would actually cost. There was a lot of feedback from folks that, you know, they just weren't sure which plans to go through because they didn't know, you know, how their prescriptions would be covered or kind of, you know, what kind of providers would be covered and things like that. So just that level of uncertainty played a very key role. Next slide, please. Another key issue, you know, honestly, this was not super surprising to me, but was access to coverage and care. And so really, when we're thinking about, you know, people being able to sign up for health insurance, but then also, can they actually use that? You know, in rural areas of the state, we heard a lot, you know, of people that said, you know, I signed up for coverage, but then I had to go a distance to be able to actually use that coverage. So networks were a big concern, access to facilities and things like that. The other thing that was very interesting was that a lot of people that were part of the focus groups were really concerned about their providers being covered because they were non-traditional. So, you know, they might go see a naturopath or acupuncturist or something like that, and they wanted to make sure that those were covered. And they didn't, there was a lot of misconceptions about certain services and types of providers that are covered a lot by marketplace plans, but kind of the misconception that they weren't. So that was definitely something that we heard loud and clear. Next slide, please. What we heard a lot was that people, you know, they want to feel like their health coverage and their health care is in their hands and that it's tailored to what they really want and what they really need. Again, as I mentioned on the previous slide, one of the biggest things that we heard was that folks who want to go see a naturopath, you know, they want that option and they have the perception that that is not something, you know, that naturopaths are not in network for any of the marketplace plans. The other thing and the other kind of side of the coin is that a lot of folks said that they wanted to make sure that
their cultural experiences and identity were taken into account by the providers that were in network. So in other words, we heard from some folks that said, I'm from, the Black community, and I want to be able to find a doctor that understands my experiences with my culture and with my identity and how that might play a role in my health. And that it was harder to find a provider that had those shared lived experiences. So that was very interesting to hear about as well. I know we've heard about things like this in the past, but it was very helpful to hear them from the focus groups and to really help shape how we talk about healthcare. Next slide, please. One of the most interesting parts of the focus groups to me was we actually asked participants what percentage of Oregonians they thought were actually covered by health coverage right now. And surprisingly, most people guessed between 30 and 75% of Oregonians. And we were talking, we made it very clear that we were talking about all types of health coverage, not just Marketplace, but Oregon Health Plan, employer coverage, Medicare, the full gambit. So to hear those percentages be quite low was actually pretty surprisingly to me. But also, when we told them that 96% of Oregonians were actually enrolled, there was a definite shock. Some people actually even questioned, where did that number come from? But yeah, it was people were very pleasantly surprised to learn that 96% of Oregonians were covered. And even though they were pleasantly surprised, there were still some of those questions that they reverted back to about, okay, well, they might be covered, but like, are they actually using their coverage? Can they actually get to a doctor? Things like that. So access to care is still, very important. Next slide, please. So there were basically, we looked at what are the benefits to having coverage. We asked for feedback on that. And then what are some of the barriers that folks see when they're trying to access coverage? And so you can see them on the screen. But a lot of times, the benefits that people brought up was, that peace of mind, that kind of safety net that they get from health coverage if something happens. It was very reassuring to me to hear that pretty much everyone that participated said, yeah, we know, we get it. Like, health coverage is important. People have been telling us this for years, we get it. But there was just like something that was stopping them from signing up potentially. And a lot of times that was the cost, how much is it going to cost me every month? If I sign up, is it even going to be worth it? Do I have to meet a high deductible before I even get to use my benefit? Are my prescriptions even going to be covered? Things like that. So, and then again, that access to actually being able to go to the doctor without having to travel long distances and things like that. Another barrier that we heard was that just confusion over the system, how health coverage works, and a lack of transparency. There was a little bit of feedback from a couple of the focus groups that they felt that health insurance companies were trying to kind of pull the wool over their eyes and get them to sign up without being super transparent about what was covered and things like that. From my personal and professional opinion, I think that stems more from the lack of understanding of how to get the information about what's covered. But I do think that there is a layer of, making sure that everything is transparent and that people are really feeling that it's transparent. Next slide, please.
Amy, why don't we pause for a moment since you just covered this focus group topic, and I think people might have some questions about this before you go on to your next set of slides. So I'm going to open this up to see if people have questions so far.
So Craig, Drew put in the chat. So Amy, do we understand what estimations were so low? I believe this was in relation to the slide regarding how many, the surprise that there's 96% of Oregonians were already insured, and the estimations were significantly lower than that.
Yeah, that's a great question. And Drew, we didn't really, to be honest, we didn't dive into like rationale too much during the focus groups. What I can say though is that just based off of some of the comments that we were hearing, I think that it's largely because it's one of the topics that people just don't talk about with like friends and family a whole lot. And so they just don't realize that people are covered. That combined with the large misconceptions of, the affordability piece and how hard it is to sign up and things like that. I think that people just didn't realize how accessible health coverage actually can be. And so a lot of what we were hearing was kind of what we've heard in the past about confusion between Oregon Health Plan and the marketplace. And people were getting us confused, getting the programs confused during the focus groups and referring us to us as OHP a few times. So I think there's just a strong layer of just ignorance, I guess, of people just not really having the facts or understanding the facts. And so then that leads to people believing that it's just too confusing and nobody has coverage. Like a lot of people just aren't doing it. Hopefully that answers your question.
It does, although it also poses then one additional question, which is this important enough for us to understand why Oregonians have a misperception? Because in setting public policy, I would imagine it could be important to understand that. In other words, voters might think we have one kind of health emergency when really coverage isn't the health emergency. It's maybe some other aspect of maybe something closer like affordability or something else about an issue. I asked the question, I don't know if this is even the right group to address that, but you raised it and we don't really understand what's behind it. And I worry that as a state, we'll be setting direction based on perhaps some misinformation.
Yeah, no, I think that's a great point. And, I'm a big fan of making decisions off of, data. And I guess Chickie's probably instilled that in me. But I think that it's definitely a point where there is an opportunity to do some more research and to do some more kind of investigation to find out. I think that we can't tackle issues effectively until we understand the kind of the root cause of the issues. So I'm 100% in agreement with you. So I would say that is an opportunity to do some additional research as we move forward. Paul?
And so taking it possibly to a different place, like this makes me think of two things. One of which is what can we do to get people connected with a navigator, to have that person to sort of bridge some of those gaps where it's just like, if you talk to someone, like you would realize there are resources out there, there are ways to, find out some of this information, and there could probably still be surprises, but at least you could see like, no, these alternative care things are covered with these various options. And then the other thing I thought about just from the committee standpoint is this would be another opportunity if Oregon had its own exchange of, again, making that information more readily available than it may be on the federal exchange of, just even in how we market, just in how we would do a state exchange of, it would give us that opportunity to really tee up, hey, we know there's this gap out here, let's market to it and have a system that can really robustly support the consumer in that shopping.
Yeah, those are both really great points, Paul. And to your first point, I do want to mention, and as I go on in the slides and I talk about our campaign focuses for this year, I think you'll see that we're really, really heavily emphasizing that there is help available from health coverage experts. One of the things that I learned from the focus groups was that there was still a large portion of people that didn't realize that there were actually people out there to help. And it was actually really cool because in one of the focus groups, I think it was the urban focus group, one of the gals had gotten help from an insurance agent, and she was actually giving out referrals to the agent during the meeting. So that was really cool. But yeah, I think that just from the feedback that we heard, that people just still don't realize that there's folks that can help, and that help is free, and that barrier doesn't really exist as well. So I think that a lot of what we were hearing was, to your point, was a lot of thoughts that were coming up were some of these barriers that are all perceptions. And that's why I was putting on the slides, I actually said perceptions, because they're not exactly correct necessarily. We know that to be true, but it's important to understand how Oregonians are perceiving the information that we're giving, and so that we can shape that information a little bit better and route people to that help and things, to your point.
Thanks.
Any other questions?
Well, Amy, I think I just wanted to clarify on the selection of the focus group. I understand the eligibility for subsidies, but were most people, how were they, did you ask them whether they had insurance, how they were covered, or whether they were covered for insurance?
Yeah, no, that's a great question. I would have to look back at the actual, documents to say certainly, but I know that those were some of the things that they did research. I don't know, we did have a professional firm that helped us with the recruiting and things like that. And so I don't know all of the ins and outs of how they, like what questions they asked necessarily, but I believe they did look at who could at least potentially be served by the marketplace. And I could look back to see if we asked them specifically if they had coverage currently.
Yeah, I'm just wondering, because even at 4% uninsured in Oregon, that's probably 170,000 people potentially, if I'm doing my math right. So we might be targeting that. We might be overrepresenting, which is a good thing, picking a group that might be, their experience is that they have more uninsured people in that cohort. So that might be.
Yeah, I can definitely say that there must have been some sort of questions in there, because as I was watching the focus groups, there were most people said that they had insurance. Some people through the marketplace. I mean, there was definitely a variety, but there were some folks that were uninsured as well. So it did seem like a good mix, but as far as what questions they asked to get that mix, that's a great question. I'm happy to do some more digging for you.
Great. Thanks for letting us pause at that moment.
Definitely. Yeah. So, so as far as our strategy for open enrollment for this year for our campaign, we are really trying to incorporate as much feedback that we got from the focus groups as we can to make sure that we're focusing less on trying to make the case to sign up for health insurance, because what we heard loud and clear from all three focus groups was that everybody knew that they needed health coverage. It wasn't a matter of trying to prove to them that health coverage was important. It was really, our strategy is going to be more focused on trying to break down some of those barriers, to remove some of the confusion, and to really help people understand what is really truly available to them. So we're going to be focusing on, really simplifying the process by getting people to the assistance that's available, and kind of really simplifying the entry point to Oregon Healthcare as OregonHealthcare.gov, so that folks can see what they qualify for, and then make the decision of if they want to move forward or not. We know that our window shopping tool, thanks to fabulous Katie Button, is really robust, and it does a lot of great things, but we want to get people there first so that they don't feel overwhelmed with the process of doing the application to figure out what they actually can get. I've also had some discussions with Katie about how we can try to implement some changes to the tool in the future, so that we can look at making the tool a little bit more robust to help people understand what is covered in terms of naturopaths and things like that. That is still something that we're trying to explore how to integrate. But also just changing, we are updating some of the language so that we can route people back to the plans if their provider isn't showing up. So for example, if they search for a naturopath or some other sort of provider, and that provider isn't showing up as in network, we want to make sure that people understand that just because they're not in our tool doesn't necessarily mean that they're not covered by the plan, that we're not showing the whole entire network on our tool and helping folks easily get back to those network search tools on the plan sites so that they can get up-to-date information to really make the best decision for them. Next slide, please. So in terms of the federal strategy, they're going largely with similar tactics to what they've done in the past. So they're really focusing a lot on, you know, sharing awareness that the IRA did extend those lower costs and those additional savings. So they're going to be focusing on that, as well as using some testimonials to carry forward those messages. Their targets are uninsured folks, the African American community, Asian and Pacific Islanders, and Native Hawaiians, Spanish speaking and English speaking Latinos. And they're going to be providing a toolkit for folks and things like that. So a lot of their tactics are going to be similar to what they've done in the past, and they're just kind of carrying that forward. Next slide, thank you. The federal strategy, as well as our strategy, is really using a mix of traditional and digital outreach strategies or campaign elements to really make sure that we're reaching the most people where they get information. And both of our strategies, the state and federal, are using direct response strategies, which we'll show you here in just a second. I'll go to the next slide. So for the state, what we're looking at is our target audiences are really trying to reach underserved communities. So folks that are part of the BIPOC community, so Black, Indigenous, and people of color, Oregon's immigrant communities, Latinx, and then also folks that are from Eastern European areas as well. We're also looking at doing a lot more messaging to folks that English is not their primary language. We have quite a bit of strategy around doing some Latino outreach and also for Russian language radio stations and print and things, as well as some of our Asian print media opportunities as well. And then we're also, I do want to mention as well, because it's not in the slide here, that we are doing a large amount of tribal strategy as well. So we are hitting tribal media, radio, and print. We are focusing a lot on rural communities, particularly Deschutes, Josephine, Coos, and Curry, as well as North Central Oregon, which includes the Dalles and Hood River. Next slide, please. Our secondary audience group is for folks that maybe were previously ineligible for marketplace financial assistance due to the family glitch. We're still working on how to kind of message the family glitch and make it accessible, because as we know, and as Katie was just describing, it is a complex topic. It's not something that's easy to describe. So we're working through that right now, but we will be pitching to the Oregon Business Journal, the Portland Business Journal, and then working with insurance agents and assisters to help share the word of this change in eligibility as well. Next slide. So our overall goals of our open enrollment campaign is obviously to increase enrollment overall. We want to get as many people covered as possible. That continues to be our primary goal, but we do want to increase subsidy eligible enrollment. So we want to encourage people to apply for financial assistance. And I do want to mention as well, because it's not on the slide, is that we also really want to make sure that folks understand cost sharing reductions. We do see that there's a lower percentage of people that enroll in silver level plans that may be eligible for cost sharing reduction. So we want to make sure to hopefully increase enrollment in those plans as well. We want to make sure to increase the percentage of people that are part of the BIPOC communities and immigrant enrollees in the marketplace. The reason for this is because You know, there is a disproportionate number of people that are part of those communities that are uninsured. And so we want to make sure that everyone has equal access to coverage and care. So we're doing this by increasing the amount of strategy that we're using specifically to where people from these communities get information already. We're really working hard to meet people where they're at and not try to share messages in areas where they just frankly may not get them. And then we want to reduce disparities in key demographic markets that we talked about before, looking at data for areas of the state where we know that there are pockets of uninsured folks, or we think. And so really targeting our efforts in those areas. Next slide, please. So for our creative plan, we do have some new video spots that are going to be going live this year. I'm really excited to say that we're doing them in the same basic style that we've done in the past. So that for those of you that have seen our spots in the past, it's the white kind of infinity space with the spokesperson. Honestly, we're just kind of stripping everything down to the basics, no pun intended, because the focus group really responded well to our basics ads. They really liked the fact that they were straightforward, they cut to the point. The spokespeople that we had in the past, William and David, both resonated very well with the audiences. They were friendly, approachable. And so we're actually using the same folks that we did in the past. So William and David are both back for a new round. And we're hoping to continue working with them going forward as well, and kind of making them. I was joking with William and David on the set saying, you guys are a new Jake from State Farm, okay? So you're in it for the long haul, which they both really loved. We do have new English and Spanish language videos. We've got some 15-second spots and some 30-second spots. And I actually got to preview them yesterday, and they look really great, so I'm really excited. And our graphics and the messaging that we're using across all of our outlets and channels are going to be very simple. Like I said, just basically routing people to our website to find local help or to preview their plan options and their savings, and to kind of work to break down some of those barriers. Next slide. I think this might be my last slide. So I wanted to put together kind of a really easy, hopefully really easy way to compare the federal campaign tactics and the state campaign tactics, so you can kind of see there is some overlap, quite a bit of overlap, I should say, in most strategies. And that was intentional because the federal strategy is really high level, trying to get people to healthcare.gov for good reason. Our state strategies are going to be more localized, hopefully resonating with Oregonians more and directing folks to our website to get help, to find local help, I should say, and to preview their plan options locally. So really trying to establish ourselves as the authority here in Oregon, with all areas of the state. So I'm not going to go through these individually. I'm sure you guys can read very well. But we do have a really robust campaign strategy, and I'm really excited for this year. I think we're in a good place. Oh, we do have one more slide. Thank you, Dawn. So we do have a public relations strategy as well that we're rolling out. So we're going to do a series of window shopping and enrollment events. We're actually doing 3 of them. We're going to do one in the Portland metro area, one in Bend, and one in Medford. We're not going to be doing one in Salem for budget reasons. The reason why we're focusing on the Portland metro area, the Bend area, and the Medford area is because those are 3 areas that have a media hub. So we can get hopefully get local press there to share and amplify the events. Whereas Salem, unfortunately, although we're the capital city, we don't have our own news station or anything like that to help broadcast. So we're hoping that we can get that shared through the Portland media. We're also going to be looking for any added value opportunities. For example, yesterday I went up to Portland and I did a really great segment with Everyday Northwest with Coin News. So looking for any opportunities like that we can really amplify the messaging and share our story. And then also, as I mentioned before, we're going to pitch stories on the family glitch going away, what it means for Oregon families, and of course, routing them to the fabulous tool that Katie mentioned earlier, so folks can see if their employer coverage is considered affordable, and then, if it's not affordable, what can they get through the marketplace? I think that was truly my last slide. Am I wrong, Don? Am I right?
No, looks like you got to the end there. Thank you, Amy. That was very complete. I'm sure people have questions. I'd love to hear from some of the producers and the. Yes, go ahead.
Hi, Amy. This is Joni. I have a question. You said that you're using tribal media. Can you identify what organizations or resources are included?
I would have to go back, Joni, that's a great question. I'd have to go back and look at my list specifically, so I'm happy to follow up with everyone. I don't remember the exact list off the top of my head, so I'd have to look back, but I'm happy to do that.
Thank you.
Thanks, Joni. Any other questions?
No question from me, of course. This is Chicky in the room. Just wanted to flag for everybody, like if you are going to be looking out for our ads, please don't look out for it November 1. Yes, November 1 is open enrollment, but we have this thing called the elections this year. And airtime and everything is very expensive during election season. So our ads will not start until November 8th. If I'm remembering correctly, we're going to wait until all the campaigning is done at the very least. And we're not competing for very expensive airtime. So we'd be happy to share all of those links when they are live. We would love for you to share them with your networks. Of course, making things go viral is part of the game these days.
Yeah, thank you.
Go ahead, Amy.
Oh, my apologies. Thank you for bringing that up, Chicky. I did mean to mention that, and I neglected to do so. So, yeah, our campaign is going to largely be going live actually on the 9th. So we're waiting until Election Day is actually over. And we are doing what's considered a flighted campaign. So we are going to be going heavier some weeks and kind of pulling back some weeks. And that's really because we're also battling with the holidays and things like that. So we'll be going a little bit lighter during the times where it quite frankly is a little bit more expensive to buy airtime. And we know that people's minds are on other things like Thanksgiving and all of the December holidays and things like that. So to give space. So we'll be going heavy in different periods, including at the end, to make sure people don't miss their deadline.
Good. Any other questions for Amy?
So Craig, while we're waiting for any folks who might have any questions, so this is a huge part of our outreach and education campaign. The marketing side is a huge integral part of our open enrollment campaigns. But please, especially for our new members, there's a lot of other things we do aside from marketing and advertising. We are also out in the field. We meet the community where they're at in outreach events, sponsorships, conferences, trainings, you name it, we're most likely there. Our team is also very, very busy at this time, training as many community partners as we can, because one of Oregon's philosophies is no wrong door. So if you come to a community partner, whether or not you're eligible for the Oregon Health Plan or the Oregon Health Insurance Marketplace, we would love for you to know, at least come and go away with some information to get you the help that you need. So we connect folks to information, we connect folks to local help, local insurance agents, and community partners who may be more experts on the Medicaid side or more experts on the marketplace side, and sometimes even Medicare. So that's our goal. We're a small team. We're a team of less than 20 people as an state-based marketplace on the federal platform. And that's the reason why we are able to do that, to be lean and mean, is because we have this huge network of community partners and insurance agents that we rely very heavily on. So all that to say, I'm saying thank you in advance to our community partners and agents, because we can't do this work without them.
Great network. Any last questions for Amy? Well, I appreciate you walking us through that, especially the visibility into the focus groups. And I understand how that feedback's helpful for marketing. And maybe as a carrier sitting here, I think some of that feedback is helpful to us as well. So maybe there's a way that we can bring that back through plan management also to carriers for the next year, particularly things that might be perceived as barriers. I think that that could go back to where these plans are established too. So that's something I took note of. And the other thing I just also want to thank you too, because you got us back on schedule, and I know that wasn't quite as you planned. So I really appreciate that, Amy.
Thank you for having me, and I'm happy to help.
Good. So we're now at the time for public comment. I saw someone maybe came online, so maybe there is somebody that wanted to comment. Open that up. So at this point, we will take a break and trying to see what would be good. 10:35, I think, is.
So it is currently 10:21.
Okay.
We are still ahead of schedule, which is welcome and unusual, but highly welcome. So if folks can come back online at 10:30, let's go 10:32, 10 minutes from now, and we'll resume then.
Great. Thanks. Back, everybody. It's 10:32. And we're ready to move on with our agenda this morning. Next up is an update on the bridge program and marketplace mitigation updates as well. And to help us with that, we have three people, Tim Sweeney, Katie Button, and Lindsay Hopper, our very own representative on the Bridge Plan Task Force, is here to give us an update. So we're starting with you, Tim. Go ahead.
Great, thank you all, and I'm gonna go on a limb and say that was Amy putting the bridge imagery on that other transition slide, and so whoever did that for the marketplace staff, well done, and thank you very much. Happy to be back to give you all an update on where things are at with the development of the bridge program, and you know, this quick overview will do a bit of background and reminder of the task force and where they are and what's coming. I'm a bit previewing some analysis that's coming over the next few weeks, and then some content really about the strategies that are getting discussed to mitigate any negative impacts to the marketplace. And so with that, we'll go into I'll try to go through this background fairly quickly, but please do let me know if I'm going a little too fast or if we need some refresher on any of this stuff. So back in the February short session, the legislature passed House Bill 4035, directing the development of a bridge program, and created a task force to kind of oversee and inform that policy development, with the legislature not going to be around for several months, just another body to help make sure that the agencies were considering all sorts of options and that there was some oversight. And so the guidelines, the broad direction is that the bridge program would provide an affordable coverage option and improve continuity of coverage for folks who are often enrolling and disenrolling in the Oregon Health Plan, in Medicaid, and in general who sometimes don't get connected to other health coverage options because of their fluctuation in income. The bill also directed the task force to develop strategies to ensure the stability of the individual market. That is sort of like what remains after folks are pulled out of the individual market into the bridge program. So next slide, please. Some additional guidance on how the task force should go about building this bridge is one that it should advance Oregon's goal to eliminate health inequities by 2030. The bill directs that the bridge program use existing coordinated care organizations, the health plans that deliver benefits to Oregon Health Plan members, that there should be little or no cost to enrollees, that the funding that we get from the federal government to pay for this program should cover the vast majority, if not all of the costs, basically to limit the state cost of this program. And last but not least, that it's ready when the public health emergency ends and we start this redetermination process for folks on the Oregon Health Plan, many of whom we think will have incomes above Medicaid eligibility and will need to go somewhere else. This bridge program is one of the design destinations for folks to make sure that they maintain health coverage when all that happens. Next slide, please. So the task force has been very busy. We've met, it has met every 2 to 3 weeks. Maybe there was a 4-week gap at one point in the summer. And started off really, you know, with some basic, you know, some of the more building blocks of what should this program be, how should we develop this program, how should we deliver this program, and into a lot more details about what's covered. And they released an initial interim report September 1st, and the next slide shows the recommendations, the interim initial recommendations, and the task force is continuing to meet this fall and will have final recommendations in December. Just to highlight a few of the, I think, more important recommendations from the interim report is that the bridge program should be established through a 1331 program, which is a basic health program that is federally funded, that there be phased implementation so that we do keep people covered when the public health emergency ends, even though the full launch of the basic health program won't be ready when that happens. They confirmed the direction of the legislature to administer the program through CCOs and to align processes with the Oregon Health Plan whenever possible. And that there should be no enrollee costs and a service package that is as close as possible to what folks are getting now through CCOs. Next slide, please. So this, to that point of the phased implementation, this is the current timeline that the task force is working towards, and that the phase, to start at the back end, phase 4 is off in the future of the potential to create a program that has an option for folks to remain in the marketplace. That is something that the task force has said should be continually looked at, but there's not a specific plan for that. So phase 3 is really sort of the full implementation of a basic health program, of the bridge program in plan year 2025. Prior to that, phases 1 and 2 would keep people who are on the marketplace, covered by marketplace plans in this 138 to 200% income range, would keep them on the marketplace over these next 2 years. But people who are covered by the Oregon Health Plan now, people who are on Medicaid and who during this redetermination process are identified as having income in this 138 to 200% range, those folks would start to move into the bridge program sooner. In phase 1, we would keep them in the Oregon Health Plan using a Medicaid expansion to keep folks covered. And then in phase 2, they would move into the basic health program funded bridge program. So there wouldn't be this like full implementation where people are leaving the marketplace until 2025. Does that, I'm going to pause here for a quick second because I feel like that was kind of a lot of information, and make sure that if anybody has any questions or clarifying opportunities that I can do that. Okay, great. And we can always revisit some of this stuff as well. Oh, okay. So where are we going next? What does the fall look like? What else is coming? So post the interim September report, we have meetings every couple weeks in the fall to dive into some of the additional actuarial analysis that just wasn't able to get done in the summer. And in the last meeting, October 4th, and this next meeting, October 18th, the focus is really on a micro simulation model of sort of what happens to the individual market once this population of people from in their income range of 138 to 200%, once they are pulled out of individual market plans and put in a basic health program, what happens to the market that's left? How do premiums change, and how do people respond to those premium changes? And then in November and into December is when we'll start to get into some more detailed programmatic cost and revenue estimates for the basic health program itself. What is it going to cost to cover the people who move from the Oregon Health Plan and who move from the marketplace, and what kind of federal revenue will we get through the basic health program funding formula? And these next few meetings will then inform the final vote in December. There's actually, and I apologize, this might be a slightly out of date slide. There's one additional meeting in between this November 15th and December 13th meeting, again, to sort of keep discussing the cost and revenue estimates. So they are, the task force is literally meeting every 2 weeks, starting last week through the middle of December. Next slide. And this just sort of shows some of the information and data analysis that they have received. Back in May, there was an initial feasibility analysis that suggested It is possible to build this program within the broad constructs of the legislation and to do it in a manner that's fully federally funded. And we had a couple, so the information in black is data that has already been presented to the task force. There was some additional follow-up looking at covered benefits between commercial plans on the marketplace and the Oregon Health Plan, and some initial analysis of the population of folks that we expect to move from the Oregon Health Plan into a basic health program. And next Tuesday, the task force will get the results of the microsimulation modeling and the impact on the residual market that remains in the individual market. And then in November, they will get some information on the estimated costs and enrollment and revenue for this program. Next slide. So over the next couple months, sort of to summarize what the task force is doing, they will be finalizing their plan design recommendations based on the data that we're bringing them to finalize whether there will be costs for members, whether the service package will need to be changed from the services currently delivered to Oregon Health Plan members, and whether any other changes need to be made so that CCOs can fully operate this program and implement it. We're working with CCOs and have a series of meetings to get their take on both the plan design ramifications. Is it possible to do X, Y, and Z, as well as the operational challenges that they see coming and how we might best address those. In addition to that, the task force is going to be finalizing their strategies to mitigate any negative impact to the remaining individual market that could happen by taking folks out. Like I said, there's this microsimulation modeling analysis that's coming to the task force on Tuesday. There's a series of meetings with representatives from each of the carriers that offer plans on the marketplace to help to sort of go over the same information with them and to use their knowledge and expertise to help design strategies to mitigate any negative impact to the marketplace. And we're constantly working with CMS to sort of explore the options that the state might have to creatively address these challenges, and in particular to get some federal funds to accomplish some of the strategies that we identify. Next slide. So the mitigation of negative impact to the marketplace is really, I think, probably the topic that y'all are most interested in. So the broad idea is that because of the loss of silver loading, so I'll take a step back, and I know that there have been silver loading presentations to the HIMAC already, but it's also complicated enough that I think maybe just a quick recap could be useful. When we move the folks from 138 to 200% out of the marketplace, this is a population that receives the cost sharing reduction plans that make silver plans more generous than they otherwise would be. And the cost of those plans are loaded into the rates, to the silver rates across the board. So when we pull those folks out of the individual market, there's less of a reason to load the costs of these cost sharing reduction plans into the cost of silver plans. And so silver premiums for on the marketplace actually go down, which is great, except for that it also means the advanced premium tax credit value also goes down because it is based on the cost of the silver plans. So we understand that for folks buying the second lowest cost silver plan, their premium doesn't change because their premium is set at a % of their income by the Affordable Care Act and subsequently by by ARPA and whatever the heck the bill was called to extend ARPA this summer that I'm blanking on. But folks who buy gold and bronze plans will see changes in their premiums because of pulling folks out of the individual market into the basic health program. And the broad idea that we've been discussing is, what can we do? What could we provide an additional subsidy to keep to help keep consumers as close to whole as possible, to account for their premium assistance losses? So folks who see bronze plans go up by a little bit, is there something we could do so that their cost increase is either lower or non-existent? So the goal is to make consumers as close to whole as we can. It's to provide subsidies that are as equitable as possible, so that we're accurately taking into account that the impact on premiums might differ based on region, based on age, based on something that is sort of out of the consumer's direct control. But also to do this in a way that minimizes complexity for the purchasers, for the carriers, for the state in administering this. And sort of the left unsaid part of this is, because we are still on the healthcare.gov platform, so that limits some of the potential options that we might have to create a really complicated subsidy scenario that achieves all of our goals, but if we can't implement it on healthcare.gov, then that kind of doesn't work. So these are the broad goals of this subsidy program. Next slide, please. So the goal, or in designing this, we're starting with this underlying reality that we've got to design a program with consideration of the federal marketplace, and data gaps in terms of what we do and don't know about how this is going to affect people and where people are covered. So the initial proposed approach is a flat amount that could be tailored based on certain factors, and the starting point would be X dollars for every policyholder purchasing on the individual market, or for everybody who's getting a subsidy now, that subsidy would be increased by some flat amount, with the potential consideration of adding of tailoring this based on family composition, basically giving extra subsidy if you've got 2 people in the household on the plan, or if you've got 3 people, an extra subsidy for that next person. And that amount could be the same across the board for every additional person on the policy. It could be the same for adults and some lower amount for kids. That is sort of still dependent on the impact that we'll see in the microsimulation modeling. And then there could be another component for age. If the modeling suggests that older people are particularly affected by this change, or that if younger people are particularly affected by this change, that we could target an additional amount to make that more fair, quote unquote. And so we'll walk through each of these components here over the next couple slides. So the next slide. A flat per policy amount is certainly the most simple to administer. One of the, and I guess I kind of didn't say this completely, one of the issues with the way it works with our setup on healthcare.gov is we are likely to have to develop a subsidy proposal that is implemented with direct payments to carriers, and something simple enough that we could tell consumers, hey, the amounts that you see on here are going to be lowered by $25 because of this extra state subsidy, but we won't be able to load that additional state subsidy into the display of healthcare.gov. There's some other ways that we can communicate that information to people, but the limitations of the federal platform in place there are one of the reasons why we're thinking about this very simple approach of just X amount of dollars. And I can make up a number. Let's say it's $25 a month per policy, and we could just say everybody knows that whatever price you see, it's $25 a month less than that. And we make these payments to the carriers on the back end, so the consumer never really has to deal with sort of understanding if they owe additional money or if they're paying the right amount. So it's administratively straightforward. It's relatively easy for consumers to understand. We can just tell them it's a lower amount by this certain number. And because premiums are already take income into account, this covers a greater share of lower income members' premiums than higher income members' premiums. So it's already somewhat tailored to the income effect of all of this. The limitation is it in its simplicity, it might not take into account all of the potential needs of consumers as a more granular subsidy might. All right, next slide. Another thing we could do is adding a subsidy amount for additional family members on the plan, either for additional adults in the household, potentially a lower amount for children, depending on what the data shows us. Again, the benefits are that it accounts for additional people on the policy. It is still relatively straightforward and easy for folks to understand. And again, the limitations are that depending on the results of the modeling, it still may not be quite equitable across the board. And the next slide, we start to talk about age. So we could have some age-based subsidies, either that would help increase affordability for older enrollees who are paying higher premiums. It could help incentivize younger folks to join the market, potentially improving the risk pool, and also to take into account some oddities where younger people may be paying, may see a bigger impact on their cost for bronze plans in particular. And it in general, the more targeted approach could address some of the inequities of the flat amount discussed previously. The limitations, however, are it just makes this more complicated, and more opportunities potentially for consumer confusion. And depending on exactly how this was structured, if it was only targeted at older enrollees, for instance, it could have an effect on the risk pool of the marketplace itself. Okay, next slide. Just a little bit about the process for how we're getting to the final decisions on this. As I mentioned, there's ongoing conversations with the 6 carriers who offer plans on the marketplace. And the next meeting of this group is tomorrow, and then some additional meetings in November, or later in October, sorry. And then that group will help inform the recommendations that get brought to the task force, and the recommendations that the task force puts in their final report. And at the same time, we're continuing to work with CMS to make sure that we could implement whatever idea or ideas that the task force lands on, as well as ways that we could get federal funding to pay for these subsidies. Next slide. Oh, great. That's it. And I would certainly welcome any thoughts from, I see Lindsay already has her hand up. That's great. Especially if I made any mistakes. I think Katie would have already corrected me if I said anything terribly wrong. But any additional nuance of what went through. Yeah, Lindsay, what's up?
I regret that I have no exciting bridge pictures or bridge puns, so I'm odd person out on that. But the photos are fun. I just wanted to flag Tim for framing the points about administrative complexity are really from a member perspective or a state perspective, what might be more or less complex, because that carrier conversation hasn't happened yet. Where I'm asking here is, I think even a flat subsidy may be really challenging to administer with any sort of source of truth on the carrier side, and just curious about your take on options if that feedback comes back in that way.
Yeah, I mean, I think it's certainly fair to say that in the meeting so far with the carriers, they've flagged, I think your general point that, you know, simplicity might not be exactly the right word in a sense of saying it's administratively simple to do this, but maybe relatively easier the cleaner this is, as opposed to getting into more complicated options. I mean, I think one of the challenges is there aren't a lot of options beyond doing something like this, right? The other ways to reduce or to make payments to carriers that would reduce the underlying premium would sort of exacerbate the challenges and reduce the APTCs more. So it kind of has to get done on the back end. But I think that is sort of the point of those carrier conversations, is to the extent that we're identifying challenges that become insurmountable, trying to get some ideas, frankly, from that group as well, to say, okay, if that doesn't work, what else could work to accomplish this, and make sure that there's still an effort to find a solution for these challenges.
How much has the state explored tying it to reinsurance, even if that's politically challenging? Just curious about that as well.
I think there's been a decent bit of exploration to it. I mean, and anything, if it's done through a 1332 waiver, it would be part of that same waiver. I mean, the direction from CMS is that just becomes another component of that waiver.
Right.
I think the challenge is, and there might be other folks who can speak to this better, but if we're making additional reinsurance payments that reduce the premiums, that doesn't solve the issue, because it's still then reducing the APTCs, and subsidized consumers aren't then seeing their that change isn't mitigated in the same fashion. If it pulls down the cost of the silver plan, they're still seeing the same increase to their bronze or gold selections as they would. And so I think that has been one of these ideas that we're like, wait, can't we just build on this program that we have, where we're already making payments directly to carriers with the goal of reducing costs, and trying to think about how that could work? But it feels like we keep running into this problem that it doesn't attack it in the same way, considering this issue. Oh, Katie, I think you're muted.
Okay. Drew, you look like you have your hand up. Do you have a question or comment?
I do have a comment. I actually have two comments, if I may. One is, I think if similar to what Timothy said about if gone through the reinsurance, it would in essence be applying the equivalent subsidy to all purchasers, as opposed to just those who would have normally qualified for the subsidy, which might have its own equity issues. It depends on your perspective, may or may not be an equity issue. But I also have a question for Timothy, which is benchmarking to gold now officially off the table? Is that now set sail and we need to stop thinking about that?
That's a great question. I really appreciate, first off, the clarity around the reinsurance side of it. My general feeling is that nothing is ever officially off the table in the CMS conversations. I think that there's a couple points that have sort of been demerits against the gold subsidy idea, or the gold benchmarking idea. And one is the regional variation, in that it doesn't adequately hold folks close to harmless, or as close to harmless as we want in some regions as it does others, and how to sort of manage that regional impact. And that the other idea is really just about whether it pencils out, in the sense of, if we can get enough federal pass-through savings to fund the additional premiums. And I think that as we've looked at it more, to me, I think the at least tentative conclusion has been that moving to the gold benchmark is more expensive than the potential pass-through we could achieve are. And there's a couple other operational concerns with healthcare.gov, and this requires more Treasury approval in the 1332. So I think that has added to some of the complexity that I don't think it's officially off the table, but that it's like it has at least caused the focus to shift more to the subsidy idea.
Thank you.
Yeah, thanks for that question, Drew. Just for the committee members' benefit, to provide a little more insight into this. So there are 3 of us that are participating in this carrier work group. So that's Drew, Paul, and myself, and then Chickies also attends the carrier mitigation work group sometimes. We have this meeting tomorrow. Of course, Tim's there as well. And my sense of this, and please, Paul or Drew, if you think differently, is that they're headed towards this subsidy approach. That seems to be the favorite approach. At least that's my sense after the last call. There are a lot of questions now of the carriers in terms of how to operationalize that. So that's part of the follow-up as well. But I also just wanted to be clear to those of you that are working with consumers, what this really means, at least as I understand it, is that the consumers will go to healthcare.gov, purchase a product, go shopping, and then have to keep in mind that they'll get an additional subsidy that will buy down that rate even further. So there's a bit of a member communication part of that feels a little clunky, my word, but that's, I think, how this is, where this is headed. I think the other thing I'll just say about this, in terms of timing, we saw, Tim, you shared the timeline. This, I might have misspoken. This is not 2024. This is probably 2025 when this really impacts us, because that's when the members move. You say something about that?
Yeah, thanks, Craig. That's exactly right. And I could have been more clear about that, but that this mitigation component becomes an issue when we move folks from the marketplace into the basic health program, which, yes, the timeline is that would be 2025. Calendar year, plan year, 2025.
Yeah, but I think for this final report and the work that we're asked to do, we want to have a solid recommendation by December. Drew, go ahead. You had your hand up.
Yeah, thanks, Craig. I kind of look at this problem we're trying to solve here as a choice between something, and it's sort of forced choice to have to give up something. And the better articulated is, if we aim for administrative simplification, then those who might have been getting a larger subsidy might get a smaller subsidy, and those that were getting, and then maybe younger individuals who might be getting a relatively small subsidy, or those individuals that living in a more affordable part of Oregon would get a larger subsidy than they would have gotten otherwise. It's sort of choosing like what is a better option, administrative simplification or perfect, like keeping what was in place, mimicking what was in place. And if mimicking what was in place is not possible, then I think we do need to recognize that there will be winners and losers in a subsidy approach. There will be those that will get larger subsidies than they would have gotten otherwise, and those that will get smaller subsidies than they would have gotten otherwise. I don't think there's a way around that.
Yeah, that's a good point. The winners and losers comment. I guess I'm curious then from committee members who, again, work with the consumers, this concept of this keeping in mind a subsidy that you would add onto your premium or buy down your premium. Do you have thoughts about that? Questions, things that we should bring to this meeting tomorrow? Thanks, Holly. Go ahead.
Thank you. I'm just curious if you have any idea what that would look like as far as the reconciliation process when consumers are filing taxes, if that's all going to kind of just be reflected on a 1095 or an additional document, and how we can best prepare them for that.
Do you want me to try to answer that, Tim? So what I think would happen, and we would have to like confirm this with CMS, but since the amount that CMS gives them is whatever would show up on the 1095, the other amount, since we're giving that to the carriers, and then the carriers are taking that off, that would come through the 1332. So I don't believe that that amount would need to be included in the 1095. So what consumers see on their healthcare.gov account and what they get on their 1095 should match and be correct. And then the other amount comes through that 1332, so it's done in a different way. But we will confirm that with CMS to make sure that's how it works.
The term subsidies may be confusing because there's the advanced premium tax credit, which is a subsidy, and then we're talking about a premium reduction. But I think the impact on the consumer is the same. The actual APTC doesn't change under this scenario.
So I have a question.
Yeah.
And I'm sorry, I muted myself. So when you're talking about the 1095 and 1032, and we're still dealing with problem of the consumer have a income fluctuations. So let's say by the end of the year, the filing tax and the income is higher than they told us. They have to pay back APTC and also the additional subsidy. Is that correct?
I think and maybe Katie is better positioned to answer this too, but I think, I mean, one of the benefits of not varying the state subsidy by income is that everybody would get the same. So there certainly wouldn't be any paying back the state subsidy. I think the vision is like that's baked in, and that would be the same whether this person was at 300% of poverty or 225. You know, I think and if we're targeting it towards folks who get APTCs, I don't think, I mean, there hasn't been a conversation that we're like, only if you would have gotten it every single month of the year or whatever. Like, so I think the vision is that there would be no needing to pay back state subsidy in the same fashion.
This is Mary Beth on the phone. Can you hear me?
Yeah.
Okay, great. So I have a question regarding going back to the timeline. Someone mentioned that, you know, this isn't really happening until 2025. Is there any contingency or flexibility that we can put in place, considering that the state is trying to get to the state-based marketplace to make this at least a little bit easier to implement these subsidies?
I mean, I guess I have a couple thoughts on that. Is one, whatever more simplified subsidy is put in place in the short term that can be done through healthcare.gov could be modified down the road once there's a state marketplace platform and the ability to include a more complicated state subsidies design. I think that would be a conversation for future policymakers and future folks to sort of like figure out and look at the gaps of the initial subsidy design and see how it could be made better. So if that's the question, I think that the structure of the subsidy can always be revisited down the road once our capability to have something that's more nuanced improves. I think if it's a question of revising the BHP timeline to accommodate the state marketplace timeline, I think that gets more complicated because of the costs involved in phases 1 and 2 and the type of federal approval that we'd need to delay that. So if that's part of the question, I think that's harder.
Okay, that's really helpful. Thank you.
Yeah, if you don't mind me following up on that, and thanks for taking that. What I understand about getting to a state-based marketplace is even if things go very well, which they should, that's 2026.
It is for open enrollment 2026 for plan year 2027. That's the current timeline.
Okay.
Yes.
Okay, so Tim, what you're referring to is if we were to delay or prolongate an initial phase that long, that's unlikely. So we really
Yeah.
don't have, okay. So having the flexibility of state-based marketplace is not going to help, at least in the initial part of this. Good. Any other questions people have?
I do, Craig. This is just my curiosity. So, earlier, Craig and Paul mentioned about state-based. So I'm sure that you envisions of this program will be successful, and with timeline of 2026 and 2027. Is that too soon for us to develop a plan for Oregon to be on state-based health insurance?
Sorry, this is Chicky. Can you repeat your question for me, please?
Yeah, the question is, I heard earlier about we kind of wanting to be a state-based health insurance instead of federal. Am I correct?
So we are currently in healthcare.gov, which is the federally facilitated marketplace, right? So we have a legislative concept put forward for ideally for approval for the 2023 session. So we need approval from the legislature, the Oregon legislature, to become our own state-based marketplace. And that current timeline is for hopefully to have one for open enrollment November 1, 2026, for open enrollment 2027.
Yeah, so that's what I'm trying to understand, that if this bridge program running successfully, that could be kind of a good evidence for us to run as a state-based insurance. Or is that tiding? It has some relation to it at all, or what? Maybe I don't make myself clear. I just want to see, is this the bridge program that you're trying to do with the state subsidy will help us promoting to be a state-based providing health insurance instead of federal?
So it could be, as Tim mentioned earlier, right? If, for example, we're not on our own exchange yet, we do maybe a flat rate version for the subsidy. And then if we get our state-based marketplace technology, we could potentially be a little bit more sophisticated with how we distribute the subsidy. So it could be a value proposition to move away. It really depends on, I guess, a variety of different things, including whether or not, it's operationally feasible, equitable, and all the considerations we need to do for our policy initiatives. Did I answer your question, Om?
Yeah, thank you. Yes.
Lindsay, question?
Thanks. Yeah, this is Lindsay. I just wanted to clarify that people who are in that 138 to 200% would be qualified for the Oregon additional subsidy, and they're not at risk of repaying that even if their income goes up.
So the folks in the 138 to 200% range are the folks who will move from the marketplace into the basic health program. The additional state subsidy is targeted really at folks 200% and above who are getting APTCs, who might see basically a change in their purchasing power for bronze and gold plans as a result of the change, as a result of pulling that other group out of the marketplace. So it's really an additional help for folks, broadly 200 to 400% of poverty, to make it so that they're not seeing significantly higher costs because of the creation of the bridge program for other folks.
I thank you for clarifying that, Tim. I think in that case, my other question is, what about the people who go from 200 to 201% FPL during the year?
I mean, I think some of this, there's some state flexibility, but as I understand it, you enroll in the basic health program at the beginning of the year. To the extent that your income changes during that year, you're not kicked off the basic health program mid-year. You but the next year when you go to sign up for a plan, if your income is above that threshold, then you would get marketplace-based coverage instead.
We wouldn't be doing that.
Yeah,
Or
wouldn't be
each
doing that. Yeah.
marketplace. Okay.
Lindsay, thank you for that question. I didn't realize that. So that is also an additional benefit of this program, is you not only reduces the churn for those between 138 and 200%, but once you're on, you're good for the year, it sounds like.
Yeah.
That's good. Yes, Joni, please.
So have we looked to see if there's any other states who have mirrored a similar model and what challenges and what successes they had? You're nodding yes.
Yes, I believe that's been part of it, but Tim, I'll let you go ahead and answer that.
Yeah, and so there's I mean, partly the answer is yes, and partly some of this subsidy issue is unique to Oregon because of the timing. So New York and Minnesota both have had basic health programs since I think 2015, and I think by most accounts, if not all accounts, have been very successful in operating those programs, and have over time been able to add benefits and reduce the cost to their enrollees on their basic health program. Because we're launching this program after the creation of silver loading, we have this unique situation where pulling this population out has this impact on APTC value for folks who remain in the individual market. So from that standpoint, this scenario where we're trying to design a state subsidy to help mitigate that issue is a little unique to Oregon.
Thank you.
And Tim, may I just add, so this is Chicky from the room, an additional difference between what we're proposing and potentially conceptualizing from Minnesota and New York is Minnesota and New York are using their own exchange technology for their basic health program as well. So their operational burdens are not, are significantly different than what we would potentially encounter.
I thought there was one other state that was looking at something now. Is it Colorado? Yeah.
So Kentucky is looking at building a basic health program as well, and Colorado did get a 1332 waiver approved to sort of I don't know if it's officially called a public option, but it's the Colorado option to sort of make some revisions to their marketplace plans. So we've talked to the Kentucky folks about how they're envisioning developing their basic health program, and while our proposal is nothing like the Colorado waiver, the way that they've structured their waiver on sort of contingent implementation of some provisions is helping us in sort of developing the structure of this subsidy proposal. But again, not that we're doing what Colorado is doing from a policy standpoint.
Good. Any other questions from people about this?
The only other last thing that I would say is just a reminder that next Tuesday, the microsimulation model results will be delivered to the task force, and there will be a lot more information about how this sort of, not just the conceptual impact that we're talking about, but what some of the initial estimates are for the impact on gold and bronze premiums for folks in different regions and at different ages and income levels, and to really sort of add the detail necessary to develop the structure of the subsidy program. So folks are interested in more information, join us next Tuesday morning for the task force meeting.
Yeah, I think we might get a preview of that tomorrow as well, Tim. I'm not sure. People that are on the carrier work group. Wasn't clear to me on the agenda what we're seeing tomorrow.
Yeah, that's the
The
hope.
simulation results were distributed though.
Okay. Well, they were or were not distributed? Sorry, Drew.
I thought there were.
I think we sent out to that group the sort of background presentation that the actuarial team gave to the task force last week that sort of like goes into some of the first step results of the model that are kind of like just what happens when you pull the population out, and then their model is then a more sophisticated look at sort of like how consumers respond and how those responses further affect rates and sort of all of that back and forth to give a more dynamic approach to the estimates. And that second half wasn't part of the presentation to the task force on October 4th, and that's what will be coming next week. So some more the more detailed information.
Well, maybe since we have a little more time, I wanted to summarize some of this for the committee and just, again, highlight why it's important to the marketplace, what we're talking about. The purpose of the bridge plan is to reduce churn for those people under 200% of federal poverty and allow them to remain where they've been, which is on Medicaid for the most part, because we haven't had redeterminations. So that's the work of the task force. And Lindsay, please feel free to clarify if I'm missing something here, but I just want people to be aware of that. I think where it starts to impact the marketplace is later on when people who are currently purchasing on the marketplace move into the bridge plan. So there are pros and cons of that. And I guess I'm bringing this up because I'd like to get a feel from people on the task force, because we are responsible for the marketplace and we have interest in that. So I just wanted to make sure people are aware of the potential impact and get some feedback. So the potential impact is people will move out of the marketplace. I think it's about 32,000 people is what the estimate is. It's not so much the number of the people, but then having those people move out, there's this disruption in terms of what the premium looks like. So there's a pro and a con, I think, or there's positives and negatives. People could stay or move into a bridge plan. There's less churn there. The benefits might be more comprehensive, less cost sharing. It looks more like a Medicaid plan. Maybe there's differences in the network, that sort of thing. We haven't really got into that. And then the flip side of that is then on the marketplace, the size decreases, and then we have this, we're working with a premium subsidy at this point, but there's some impact there. So that might have been, I don't know if that actually helped clarify anything, but I guess I'm curious, just at a high level, what people think about moving down this path and whether it's worth the challenges to the marketplace to accomplish this goal, what we're trying to do with those under 200% of poverty. If anybody wants to offer up their thoughts on that.
I would say that I know it can be a sticker shock for those who no longer qualify for OHP to still have coverage through the marketplace. And then we risk them declining to be insured. And so I think if there can be a successful program that you're moving forward to implementing, I think that would be a good bridge, transitional bridge for these lower income folks to still stay insured, but just it's a gradual financial cost sharing to them instead of taking such a large hit moving into the marketplace.
Yeah.
I see that quite a bit.
I appreciate that perspective. I think that's the policy objective of this, but there are low cost share variants. I mean, there's lower cost sharing for people who have lower income. So I don't know, does that help? Does that help offset some of that impact of the sticker shock?
But when they're on OHP, they're not paying anything. Yeah. And so for a lot of the consumers who do have lower income, it's not just their healthcare costs that that they become responsible to contribute to, it's, their food stamp subsidy is declined. And so there's a multitude of different cost sharings that can be overwhelming to them, and health insurance is one of the first things that they let go. And that's what we don't want to see that.
That's good. Thank you.
I just wanted to chime in from a quick policy standpoint it's kind of absolutely the policy rationale behind the creation of the basic health program. And I think one data point that we've included in previous presentations is that prior to COVID, prior to the public health emergencies continuous coverage provisions, the 138 to 200% group in Oregon was the most likely to be uninsured. Their uninsured rate pre-COVID was about 18%, and we've seen through the Oregon Health Insurance Survey data that has dropped to about 8% in 2021. So that is, I think to that point, the rationale for targeting the 138 to 200% of the population for a new program, and certainly to Craig's point, the reasoning behind the mitigation effort is to make sure in doing that we don't create other problems. And so trying to figure out how to direct additional resources to the folks above 200% who remain on the marketplace, so that they also don't have any reduced affordability or substantially reduced affordability because of that.
Drew, you have your hand up.
Thanks. I'm not, this is not to indicate, sorry, I'll just say there is one, Craig, you asked about marketplace considerations with respect to the bridge plan. And I think it is important for us to also reflect that there might be some additional cost shifting by providers into commercial products. If at least the task force presentations that have been presented so far indicate that the bridge plan would likely have reimbursement rates below current commercial rates, maybe something, and since if it would be administered by CCOs, it might be something akin to a Medicaid rate. 50,000 someone or 35,000 someone Oregonians then who might have been have reimbursement tied to a commercial rate will now have reimbursement tied to a Medicaid rate or something closer. And it's likely that providers will cost shift to the remaining exchange and employer sponsored products. I haven't seen a study to indicate what the size of that additional cost shift would be, but the direction is likely increased cost amongst those not below 200% of the FPL. Those above 200% of the FPL. That's important marketplace consideration that we haven't yet looked at. It might be immaterial, but it might not be. We don't know.
I'm glad you raised that point. Do we know if that's something that the task force will be looking into as part of the micro simulation? Does that sound familiar, Lindsay, since you're our representative? Put you on the spot.
I mean, this topic has come up multiple times, right? And we sort of, as I recall, needed to push some of the conversation a little bit later in the fall, but we've been raising the question of these reimbursement rates and what might happen to the rest of the market, what might happen even for network participation. So I think that the initial report really preserved those items for more discussion. Tim, do I have that characterization correct?
Yeah, I mean, I think that that's right. It has come up some. I mean, we have not had an in-depth cost shift conversation with the task force. I mean, I think I would just note that it's, certainly healthcare markets are complicated and there's a lot of moving pieces, and sort of how, the research on cost shifting is, in general, it's kind of all over the place. And I think it would be interesting to dive more into it. as much as 30,000 people will come from the marketplace. I think initial estimates are also that there will be folks who are coming from not being insured at all into this program. So there's potential reimbursement coming for folks who were not getting covered before. And so what implications that might be. And again, just an overall contextualizing that, full implementation of this program is something in the neighborhood of 100,000 people in a state of 4 million people. So it's hard to feel like that it's going to have a monumental impact on prices felt across the market when some of these folks are certainly in Medicaid already. Some of them are going to be coming from uninsured, and certainly some will be coming from commercial plans.
Good, thank you for that, Tim. Any other comments? There's one more piece of business on this topic that I wanted to cover, but I just want to make sure everybody had a chance who wanted to offer comments on this topic to go ahead. Okay, looks like it's good. So Lindsay Hopper, I think you sent out a request about the consumer engagement. That might have been last week, if I'm not mistaken. Is there anything you wanted to say as a follow-up on that?
Oh, thank you. Chicky was kind enough to send out a request that we had and bring your feedback back. I shared that with staff associated with the task force presentation, and we had a conversation about consumer engagement. And I think that topic, remains open for more feedback about this pre-implementation stage. So I wanted to thank everyone who provided feedback. Thank you, Chicky, for carrying that forward. I did close the loop on that, and more conversation to come. I think we all acknowledged I heard a lot of consensus around the importance of the conversation, and also with so many pieces in play, in flux, levers that need to be ironed out this fall. It's a little difficult to seek feedback with all of those uncertainties. And so we did discuss some elements of when timing might be most appropriate. I don't know if Mr. Sweeney or others have anything to add, but that was sort of the conversation we had at the last meeting, as I would capture it.
So Lindsay, out of curiosity, it's getting consumer feedback, and we spent a lot of time in this meeting talking about the bridge program, but that's a fraction of those who lose coverage on OHP. So is this comprehensive to make sure that we're getting feedback from all consumers that will be impacted through the redetermination process?
So there's a separate work group really focused on community and member engagement in that process. The conversation we had at the task force was focused in that space on pre-implementation or post-implementation feedback from consumers around the bridge. But there is that other mechanism in place, and that group, as I understand it, is meeting regularly and bringing forward feedback.
Okay, thanks for that clarification. All right, so I think we're moving on to our next topic, which is other committee business. The first item on that list is the election of the chair and the vice chair.
And I would be happy to take that section over. So thank you, Tim, Katie, and Lindsay for the Bridge program update, as well as the robust discussion. So moving over to other committee business. So thank you, Craig, for your acting role for the last few months, especially since we brought in actually one of our largest groups of new members this ever since the Health Insurance Marketplace Advisory Committee was formed in 2015. So you have in your handouts brief bios and statements from our two nominees that committee members, of course, have nominated. We have Mr. Craig Anderson has been nominated for the chair position, and Lindsay Hopper for the vice chair position. So please review, if you haven't already, the handouts have those information. And I would like to officially open and call for a first motion and a second motion for Mr. Craig Anderson for Chair of the Health Insurance Marketplace Advisory Committee.
Ron Gallinat, I so moved.
Thank you, Ron, for first motion. Second motion?
Lindsay Shirahama, I'll give the second motion.
Thank you, Lindsay. All those in favor from the committee, please, if you are virtual, please put your thumbs up, your virtual thumb up. And if you are in the room, and I'm just looking at Joni, please say aye. Or Craig, if you would also like to say aye.
Aye.
Okay, I see actual thumbs up and yellow thumbs up, so thank you, everybody. So I would like to formally introduce you to your 22 onwards Health Insurance Marketplace Advisory Committee Chair, Mr. Craig Anderson. Thank you so much for, I'm assuming you're accepting that nomination as I'm staring at you.
Outcome, but I feel better now.
As I'm staring at you and not giving you a chance to say no. Before we offer comments for Mr. Anderson, next order of business, of course, is for Ms. Lindsay Hopper as Vice Chair of the HIMAC. First motion and second motion, please.
Ron Gallinat, so moved.
Thank you for first motion. Ron, second?
This is Paul. I can second.
Thank you, Paul. All those in favor in the virtual room, thumbs up. And in the actual room, you can also do your thumbs up too. Voting members, please.
Aye.
And there we have it, folks. We have Ms. Lindsay Hopper as the 22 onwards Health Insurance Marketplace Advisory Committee Vice Chair, as approved by this committee on October 13th, 2022. I am being very, very formal because this is being recorded, and we will also put that also in our minutes. Before we move on to the next order of business, which will be led by Craig, Craig or Lindsay, any words you would like to share other than thank you, and hopefully you're not scared.
No, I appreciate the opportunity to be the chair of this committee. When I joined a few years ago, it was just really something I've felt is very important to Oregon, the marketplace, the people that we cover through this. And as I mentioned in some of my comments, I think we have some challenges ahead of us, but I think this is a great group of people. You've all been selected for your expertise, and I look forward to working with you all on committee business in the future. So thanks everyone for your confidence in me on that.
Thank you, Craig. Lindsay?
I would just say thanks very much for the opportunity. Looking forward to working with all of you. I wish I had an official thumbs up button on my emoticon list of choices. Instead, I'll just type it into the box. But anyway, thank you very much and looking forward to the work.
Okay, Mr. Chair, our next order of business is approving the revised version of the Marketplace Advisory Committee bylaws. You also have that in your handout packet, everybody. And any new changes proposed are highlighted in yellow and also in red text in the handouts.
Yeah, and I'll just mention that as I went through this, since the last time this was approved, that the majority of these changes reflect the Oregon Health Authority's focus on health equity and also the governor's goal of ending health inequities by 2030. There are a couple other updates that are in here as well, but that's the primary focus, which I think is appropriate given where we are today versus where we were when we last approved these. So is there any, beyond that, are there any discussions or questions about the bylaws? Well, hearing none, then can I get a motion to approve the bylaws as they've been updated?
This is Paul. I can motion.
Thank you, Paul. Do I have a second?
Ron Gallinat, I'll second.
Okay. Thank you, Ron.
All those in favor, please thumbs up or say aye.
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 Opposed? Okay, good.
So thank you, everybody. We will update this charter and send it out to you all. We will remove the highlighted sections, update the community chair's name to Craig Anderson, and also update the date of when this new version has been updated to October 13th, 2022.
Thank you. Next on the agenda is an additional public comment period. So we're a little bit ahead of schedule, but I think we're close enough to go ahead and open that up to see if there's anybody who'd like to make a comment.
And if you are having any issues with unmuting, I believe it is *6 on your phone if you need to.
Okay, not hearing any, we'll move on to closing. Chicky actually would like to do a preview of next meeting for us.
Yes, so our next meeting, as I quickly go over my calendar, is on December 8th from 9 a.m. to 12 p.m. It will also, again, be in a hybrid version. We encourage folks, if you would like to come in, please, you're more than welcome to come over here at the HSB building, 500 Summer Street in Salem. Of course, you're also welcome to join virtually. I recognize that December 8th is definitely in the midst of open enrollment season, so I can imagine our insurance agents and our community partners may or may not completely understand it, especially if you're rushing towards the December 15th deadline for January 1st coverage. We completely understand. But of course, you'll still get a copy of all our materials. For our next meeting, we have in the work plan identified as topics. So especially if we hear in November that the public health emergency is going to end on January 13th, 2023, we will definitely want to talk about our outreach strategies for the marketplace, the Medicaid migration to the marketplace for those 200% FPL and above coming over to the marketplace from the Oregon Health Plan. We would also like to cover member transition experience with details as we have them. I believe it was Lindsay who mentioned there is a community partner and work group team that Gladys Batwell and Ashoba Temperley have both share the HIMAC seat on, and they regularly attend that. We would love to provide updates as we have them, including any information on how populations are currently phased, because the whole public health emergency unwinding, the state has about 14 months to do so. And so there's going to be populations that will be redetermined sooner, and some will be later, depending on certain needs and criteria. So we'd like to provide an update by then. As well as, of course, if we have any additional, I'm sure we'll have updates about the basic health program. There's a lot of conversation happening between the carriers and the task force with the micro simulations, reports, so on and so forth. So December 8th would actually be a very good time to provide additional updates about the basic health program, including marketplace mitigation impacts. And as I mentioned, did I forget? Open enrollment starts November 1st, so we will also be happy to provide open enrollment numbers as we have them and as we are allowed to share data by healthcare.gov. We do get some data sometimes, but a lot of them is embargoed until, of course, the federal government shares that information publicly, and then we are allowed to share that. So lots of things to talk about, but please know if there's something that you hear about that you would like for us to cover on December 8th, we will send our usual call for agenda items email. You don't need to wait for that, of course. You can just email us at any time, say, hey, let's talk about this at December 8th. We usually have a lot of time. I mean, so depending on the day, right? So today we were running early. We have 3 hours. Again, we'll try to fit in as many of your requests as possible. So those are kind of my heads up for December 8th. We have lots of things to do, including getting as many Oregonians signed up for health insurance coverage for January 1st, 2023.
Yeah, good, exciting times. Thank you for that, Chicky. I do encourage people to join us in person. Dawn does a great job bringing snacks, so it's a welcoming environment here. And thanks, Joni, for joining us for your first meeting.
Thanks for having me. Yeah,
Appreciate your feedback today. Okay, well, with that, I'm going to close the meeting. Thanks, everyone.
Thank you, everybody.